Hello. We want to continue our study in antibiotics. We've looked at various antibiotic classes, which we called cell wall synthesis inhibitors. Basically, 5 members in that group, those that are the beta-lactam antibiotics, and then the glycopeptides. Now, today we want to look at another mechanism by which some antibiotics are able to achieve their activity of either halting the growth of bacteria or killing the bacteria. So that is through the process of bacteria protein synthesis inhibition. In other words, these antibiotics inhibit bacteria from synthesizing the necessary proteins it requires for growth and survival. Okay, now, mostly like all organisms, the ribosome is the primary system mechanism by which proteins are made. Bacteria are no exception. The ribosome that is used in making protein is a large unit of 2 subunits, one small subunit and a larger subunit. The large subunit is known as the 50S subunit, whereas the small subunit is known as the 30S subunit. The total subunit, however, is known as the 70S subunit. So we're basically saying that the ribosome 70S subunit is the enzyme, the bacteria tool for making protein or for synthesizing protein. So the group of antibiotics that are known as bacteria protein synthesis inhibitors inhibit either the larger subunit or the smaller subunit, and inhibiting it interrupt the process of cell wall synthesis. So at a glance, let's look at some of these antibiotics. So if you take the 30S subunit, aminoglycosides and tetracyclines are known to be those that bind to the 30S subunit and interfere with bacterial protein synthesis. On the other hand, for the 50S, we have the chloramphenicol, the macrolides, and then the lincosamides, which also inhibit the 50S subunit and interfere with bacterial protein synthesis. A simple acronym by which we remember which examples belong to which group. Basically, when we remember 30S and 50S, 30S representing the 30S subunit, and 50S representing the 50S subunit, we simply say that you buy at 30 and you sell at 50. So aminoglycoside and tetracyclines, the at part is the 30S, whereas the 50S is cell. And note how we spell the cell, C-E-L-L, where the C is chloramphenicol, the E is representing the macrolide group, the thromycin group, lincomycin and clindamycin representing the lincosamide group. So now let's look at these things in a little bit of details. Let's start with our aminoglycosides. Aminoglycosides are a group of antibiotics. From our nomenclature, we noted that when they have a no in the name, it's actually mostly for gram-negative organisms. Aminoglycosides are for gram-negative bacteria. Members of this group, I use TANK to help me remember. It's TANK G, where S is streptomycin, tobramycin, amikacin, neomycin, nitromycin, and kinamycin. Then gentamicin, which is the most popular member and the prototype member of the group. So the first thing we want to know about aminoglycoside, as we've stated, is they are for gram-negative organisms. We should also note that aminoglycosides do not have activity against anaerobic bacteria. They are not able to kill anaerobic bacteria. So they don't have activity against anaerobic bacteria. And this is so because we are told that because these organisms do not require oxygen to survive and proliferate and to grow, whereas aminoglycosides require oxygen so that it can have its activity. There must be an uptake of oxygen to help the aminoglycoside enter into the bacteria. And because these group of bacteria do not use oxygen, do not require oxygen in order to survive, then the activation of the aminoglycosides do not occur. And once it's not activated, it's not able to deal with the organism. So aminoglycosides are useless against anaerobic bacteria, the same way they are also useless against gram-positive organisms. When it comes to aminoglycoside, the acronym NOT helps us remember a lot of things about aminoglycosides. The first thing is that NOT help us remember the aminoglycoside side effect or adverse effect. The first side effect is the fact that it affects the renal system anemically, the nephrotoxicity. In fact, it is such that they actually measure the level of toxicity through measuring the creatinine that usually comes out in urine when we use aminoglycoside. The second thing is its ototoxicity. And in this case, its effect in the ear. And there are basically two main effects that it causes in the ear. The first is the fact that it causes balance problems, so vestibular damages leading to balance problems. It also causes ototoxicity, as we're seeing here. It causes hearing problems, auditory damage. Sometimes that can manifest as tinnitus, or it can manifest as hearing loss. And aminoglycosides should be avoided in pregnancy because of their teratogenic effects. Because of their teratogenic effects. A quick look at some of its pharmacokinetic properties. Aminoglycosides are poorly absorbed when taken orally. Because of that, aminoglycosides are usually, we do not use them orally. We avoid the oral route. Secondly, if you give aminoglycoside by the IM route, the absorption is superb. It's very good, well absorbed when given by the IM. So aminoglycosides are usually given by the IM route. We also have its use in topical regions like the eye, the ear. Now here we're taking advantage of the fact that the absorption is poor, and therefore we have very less systemic side effects. Clinically, aminoglycosides are used for gram-negative infections, serious gram-negative infections. And the infection can be anywhere, including eye-ear infections, where we are using the topical ones. It could also be a systemic infection where we'll be using the IM route, tuberculosis, pyelonephritis, prostatitis. All of these are areas where we use aminoglycoside. The agent is eliminated by the kidney, and unfortunately, that is also how it causes its nephrotoxicity. However, we want to note that they use the creatinine levels to monitor the level of damage that it is causing the kidney. So it's been shown that the excretion is directly proportional to the creatinine clearance. The adverse effect we noted as not: first, nephrotoxicity. Second, we said it causes ototoxicity, and ototoxicity can occur in two ways: vestibular damage, and then it can also cause auditory damage, which is manifested as tinnitus or hearing loss. Now, this is because of its effect on the eighth cranial nerve, so-called vestibular cochlear nerve, which is found in the ear. Now, its effect or damage to this nerve is actually what results in its ototoxic effects. It's been shown that aminoglycosides like amikacin, kanamycin, neomycin, what I like to call ACAN, usually are the ones that give us the most ototoxic effects, whereas the aminoglycosides like streptomycin, gentamicin are the ones that gives us the most vestibular toxic effect. One way I used to remember these is basically note ototoxicity is the shorter damage problem or the shorter problem. It has the longest acronym or the longer acronym, whereas the vestibular damage, which is the longer damage or problem, adverse effect, has the shorter acronym. The second antibiotic group that causes or that works through the 30S ribosome are the tetracyclines, named after their chemical structure. You can see a 4-cycline group, so they are the tetracyclines. Normally, we classify them based on their half-life, so they can be classified into the shorter acting group, which acts within 6 to 8 hours, the intermediate acting group, which acts within 8 to 12 hours, and the long acting group, which acts within 12 to 16 hours. Example of our short acting group include chlortetracycline, tetracycline, and oxytetracycline. And those of the intermediate group include demiclocycline and metacycline, and the long-acting group include doxycycline, minocycline, and meclocycline. Tetracyclines are generally described as broad-spectrum antibiotics, meaning they have effect on both gram-positive and gram-negative organisms. They are used in a variety of bacterial infections. Again, as we stated earlier, they work through the 30S ribosome. By inhibiting the 30S ribosome, they are able to exert their effect. So we've used the tetracyclines for infections such as CNS infections like meningitis, respiratory infections like pneumonia, GI infections like cholera, skin infections like acne. We've used it for genitourinary infections like chlamydia, like syphilis, and we've also used it in spotted fever, Lyme spotted fever. We've used it in Lyme's disease, We've used it in anthrax. We've used it in Rocky Mountain spotted fever. So even though in those instances it's rarely used, but we can also use, and also the conditions are also rare, and therefore we don't have the opportunity to use them. If you look at the pharmacokinetic of the drug, tetracyclines have been known to distribute very well into tissues as well as body fluids. The exception to this is that they are not distributed well in cerebrospinal fluids. But for other tissues, vaginal tissues, and fluids like vaginal fluids, prostate fluids, they are able to penetrate and distribute well in those sites. We should note that minocycline can reach very high concentrations in tears and in saliva, and therefore they are very good and useful when we want to use it in managing or helping prevent the spread of meningococcal from carrier persons. It's actually useful for the eradication of meningococcal carrier states. Tetracyclines are also eliminated mostly by the kidney, with the exception of doxycycline, which is eliminated by the bile in feces. So it's the only tetracycline that is not eliminated by the kidney, but in bile to feces. Tetracyclines affect our liver, and they also can affect the kidney. So they have a nephrotoxic adverse effect and hepatotoxic adverse effect. For demiclocycline, mostly, but for other tetracyclines, there's also the ability to induce sensitivity to sunlight, photosensitivity, and they can also cause vestibular reactions. Doxycycline, minocycline have been noted to do that. When it comes to tetracyclines, the main mechanism by which bacteria has been seen to develop resistance is by decreasing the amount of tetracycline that are accumulating in them. And there are two ways they can do that. They can either prevent the tetracycline from entering in through impairing the influx, or the one that has entered in can be actively effluxed out. And it's been shown this decrease in permeability and decrease in the amount that the tetracyclines accumulating in the organism actually is how the organism have developed resistance to our tetracycline. Because tetracyclines can cross tissues, it's been shown that they can cross the placenta and reach fetus, and therefore should be avoided in pregnancy. It can also cross the mammalian gland into breast milk, and so should also be avoided in lactating mothers. One reason why we don't want lactating mothers to give is that tetracycline has been shown to chelate or bind to calcium. And once they bind to calcium, the organs or tissues in the body that uses calcium, like when the teeth is being formed or when bones are being formed, all these require calcium. Tetracyclines are known to bind to that for children, breastfeeding children, where the element or the drug can be found in the breast milk. It binds to these and sometimes can cause discoloration of the teeth of the children. And interestingly, this can be a lifelong problem. So do not give tetracyclines to pregnant women. Do not give it to breastfeeding mothers. Do not give it to children. Children are going to affect their developing bones and their teeth. So those are the two that deal with the 30S subunit. Now let's look at the 50S subunit. Of the 50S subunit, chloramphenicol is the first member. Chloramphenicol. Now, chloramphenicol is known usually to be bacteriostatic. It acts by binding to the 50S subunit of our ribosome and interfering with bacteria protein synthesis. It is usually reserved for life-threatening infections because of the fact that even though it's effective, it also has some serious adverse effects. These adverse effects associated primarily with the fact that it binds to human ribosome or human mitochondrial ribosomes. So the same activity it does in bacteria is replicated in man, and in doing so causes adverse effects in man. Chloramphenicol has good oral absorption, and it can be applied topically, as in chloramphenicol eye ointment or drop. Distribution is known to be good in tissues, excellent in body tissues. The challenge is, like we stated earlier, it can depress the bone marrow function, and in doing so can cause red blood cell deficiency, can cause also white blood cell deficiency, can actually also cause damage of the red blood cell. Mostly this manifests as anemia, which sometimes is reversible and occasionally is irreversible, where the bone marrow is destroyed. Interestingly, the adverse effects can occur several months later, not immediately, several months later after the medication has been stopped. So that is another thing we want to be aware of. Now, we do not want to use chloramphenicol in neonates and in pregnant women, especially in the last trimester. And this is because for neonates, because of their immature liver, they don't have the capacity to remove chloramphenicol. And that will lead to an accumulation of the chloramphenicol in their system. And high concentrations of chloramphenicol is what leads to the serious side effect, as it binds to human mitochondrion and inhibits the human mitochondrial function. For children and neonates, it manifests as gray baby syndrome. This you can see in symptoms like vomiting, restlessness, hypothermia, etc. This is gray baby syndrome. So, chloramphenicol. The second member that works through the 50S ribosome are the macrolides. The macrolides. These inhibit the 50S ribosome, interfere with bacterial protein synthesis, and leads usually to the halting of the bacterial growth. Macrolides are usually used for gram-positive organisms. They have some slight activity against gram-negative organisms, but mostly for gram-positive organisms. Typically, erythromycin, azithromycin, clarithromycin are the members of the macrolide group. As we stated earlier, they are identified as the thromycin. We have the oral drugs, and we are using them for bacterial infection, again, mostly gram-positive bacterial infection, infections of the respiratory system, infections of the genital or the reproductive system, infections of the urinary tract, and infections of the GI tract. Because of the effect of macrolides on liver enzymes, especially erythromycin and clarithromycin, azithromycin has been found to have no major effect on liver enzymes and therefore do not have drug-drug interactions. However, erythromycin, clarithromycin has been shown to inhibit cytochrome 3A4 enzymes, which are found in the liver cytochrome system, cytochrome P450 system. Now, these are a group of enzymes that have been shown to also metabolize drugs like theophylline, digoxin, carbamazine, phenytoin, warfarin, ergot, etc. Now, because it's the same enzyme that inhibits these other drugs, when it is given together with erythromycin or clarithromycin, these macrolides inhibit the activity of the enzyme. Thus, the enzyme's ability to metabolize these other drugs. And in doing so, it ends up reducing the amount of these other drugs that are metabolized. And this could lead to an increase in the concentration of these other drugs, resulting in adverse effects, resulting in toxicity. If you look at the pharmacokinetics of the macrolides, erythromycin has been known to be poorly soluble in water, and therefore it is made usually as an ester or as a salt, the stearate salt. These ones are better in terms of absorption, and they are also able to resist the acid in the GI tract. Also, they use enteric coating as a way to protect the molecule erythromycin as it goes through the GI tract. Because without the enteric coating, the drug is usually destroyed by the acid in the stomach. And therefore, the drug has to be administered by the enteric coating. Clarithromycin is a derivative of erythromycin, but it has the advantage of a better absorption when you compare to erythromycin, and it has the advantage of better stability in the stomach acid. Azithromycin, on the other hand, can also be taken orally. It is very well tolerated when taken orally, and its absorption is excellent. Macrolides are distributed well into most tissues and fluids, except for the brain and for the CSF, the cerebrospinal fluid. And this is mostly because of their large molecule, because they are larger molecules. They are eliminated usually in the bile as feces or in feces. So erythromycin, azithromycin are mostly eliminated bile or in feces, lost in feces. Clarithromycin, on the other hand, is eliminated by the kidney or the renal system. We are using it for bacterial infection of the respiratory system, genitourinary system, the gastrointestinal systems, or infections of these systems or these organs have been used. Now, again, we want to emphasize that it is mostly for gram-positive organisms. They are being used as a very good substitute for patients that are allergic to our penicillins and other beta-lactam antibiotics. So if there's streptomycin, if there's staphylococcus infection, there's streptococcus infection, there's pneumococcus infection, these are all gram-positive infections. We can substitute our macrolides for our penicillins if our patients are allergic to our penicillins. Side effects include anorexia, nausea, vomiting, and diarrhea, GI side effects. And because these drugs have effect on the liver, especially erythromycin and its derivative clarithromycin, it's been shown that these can affect the liver anemically. It can cause liver inflammations. Now, the next group that deals with our 50S ribosome is the lincosamides, typically represented by lincomycin and clindamycin. We'll be using clindamycin as our drug to represent our lincosamide. Clindamycin is effective against streptococcus, staphylococcus, bacteroids, and other anaerobes. And it has activity over both gram-positive and gram-negative infections. Now, clindamycin is well absorbed when taken orally, also penetrates very well into most tissues. Clindamycin is eliminated either by the liver, the bowel, or by the renal system. We are using clindamycin clinically for anaerobic infections, those that are caused by bacteroids. We are using it for cellulitis, and it's also being used in combination with other agents for treatment and or prophylaxis. So we are using it in prophylaxis to prevent risk of infection, endocarditis, if a patient is to undergo some dental procedures. We try to use the agent to prevent infective endocarditis. Clindamycin has been combined with primaquine as a way of managing pneumonia caused by pneumocystic carinea. It's been combined with pyrimethamine, and it's used for AIDS-related toxoplasmosis. And it's also used with with quinine for malaria management, especially in the first trimester, as per our STG, the Ghana Standard Treatment Guideline. So these are the agents that do protein synthesis inhibition and help us to deal with bacteria. So again, as a quick reminder, we said they are the 30S ribosome inhibitors, and these are the aminoglycosides and the tetracyclines, and then they are the 50S subunit inhibitors, and these are the chloramphenicol, the macrolides, and the lincosamides. Thank you once again very much. The Lord bless you indeed, keep you. Please don't forget to subscribe to the channel. Have a wonderful, wonderful day. God bless.